Hello, everyone. This season, we're going to talk about taking that next step and managing patients with more complex pathologies. To reflect for a moment, we've gone through already how to set up a program, how to approach opening the atrium, closing the atrium, doing a Cox-Maze procedure for surgical ablation, and approaching type 2 or degenerative primary mitral regurgitation through different methods and mechanisms. Now we're going to talk about type 3 disease, which is restriction of the leaflets when there's lack of mobility. The goal of these types of patients is to restore mobility, relieve restriction, and have an excellent zone of coaptation that is always focused on durability. Sometimes patients have mitral annular calcification, or MAC, and sometimes these patients are very complex and need a replacement. In this first episode, we're going to talk about a patient that has type 3A disease, also in the setting of atrial functional mitral regurgitation. Let's see how we approach this patient.
Now, some of the more difficult challenges occur when it's not purely type 2 disease, but actually mixed or type 3 disease or restrictive disease. In this particular case, this is a 80-year-old gentleman presenting with coronary artery disease undergoing percutaneous coronary intervention, as well as atrial fibrillation that you can see has anterior leaflet override due to restrictive disease, not necessarily prolapse. This is a distinctive presentation that may be interpreted as prolapse, but is actually restrictive type 3 disease. As you can see, the posterior leaflet is somewhat tethered, but normal. And in this case, we're doing anterior chordal release and repositioning, while replacement, of course, is a reasonable option in patients with type 3 disease and very accepted. In some cases, it's not absolute, that one doesn't have to automatically replace. When the leaflet tissues are normal and the annular dimensions are reasonable and the degree of tethering is reasonable, it is absolutely possible and feasible to create a durable repair. As you can see, just by anterior leaflet release of the secondary chordae that you could probably see on the 3D vision of the TEE with some restriction and puckering. In this case, we had some robust chords at A2, and we're just reattaching them. It's fairly straightforward, does not burn any bridges, and it is something that can be done in a fairly focal manner. Again, one of the advantages of robotic surgery, one can get underneath the anterior leaflet and see all of these very, very beautiful. And so this is a figure of 8 or running stitch to reattach them, and then a restrictive annuloplasty to complete the repair. One can note the normal leaflet motion of both the anterior and posterior leaflet now, and this would bode for longer-term success. So overall, repair is definitely feasible in patients with anterior leaflet override, but you need to be ready for it based on the preoperative imaging.
So now we've seen how to repair type 3A disease when there's a setting of restriction. In our next episode, we're going to talk about when the combination of disease states exists. Type 2 or excess motion in the setting of combined type 3 disease or restriction. Join us.